and start. Alrighty, so we'll just wait for everybody to kind of pile on in. So I'll give it a minute or two or so. Hi, everyone. Thank you so much for joining. We're going to get started in just a few minutes, probably around 12:02 or so, just to let more people come in. But thank you so much for joining. And I heard the last session was great, and I watched some of it, and it seemed very interesting, the whole aspect of integrative medicine and women's health. So pretty cool stuff. Let us know in the chat what you thought about the last session as well. Alrighty, everyone. Apologies for the delay in start, but I think we can go ahead and get started now. I am honored to present our three speakers for today. The first speaker is Dr. Brus-Ramer. Dr. Brus-Ramer is a board-certified neuroradiologist and both the founder and president of Elite Medical Prep, a company that specializes in the tutoring for the MCAT, USMLE, COMLEX, and post-medical school exams, as well as doing general advising for medical school and residency admissions. Dr. Zielinksi is our second speaker. She's currently a PGY4 orthopedic surgery resident at Indiana University School of Medicine and a senior tutor at Elite Medical Prep. And our final speaker is Dr. Kim. Dr. Kim is currently a PGY2 ophthalmology resident at the University of Cincinnati, a tutor at Elite Medical Prep, and an accomplished violinist. Each of these three speakers, Dr. Brus-Ramer, Dr. Zielinksi, and Dr. Kim, will briefly review through their academic careers and some of the key decision points they made along the way as they decided on their choice of a surgical versus non-surgical specialty. Please give a very, very warm welcome to our speakers from Elite Medical Prep.
Avi, thanks for having us here today. I'm going to share my screen so we can put our slides up. And as noted, hopefully everybody can see that. Just give me a thumbs up or a thumbs down if you cannot see those slides. So we're going to talk today about choosing between a surgical and non-surgical career. This will be a panel discussion with both myself and my two colleagues. So as noted, I'm Dr. Brus-Ramer, and I'm a radiologist, but I also help found Elite Medical Prep. We have Dr. Zielinksi, who is an orthopedic surgery resident, and Dr. Kim, who is an ophthalmology resident, as mentioned. And we'll be talking more about our bios shortly. So we'll get to that. We'll save time and get to that. We're just by way of disclosure and also background, we all work with Elite Medical Prep. As I mentioned, I helped found the company. It's focused on one-on-one tutoring and customized educational programs for all the USMLE and COMLEX exams, also shelf exams, residency matching, the MCAT, and medical admissions advising. We also have a lot of partnerships with medical schools, including Mount Sinai, UNLV, and several other medical schools abroad. And that's sort of a growing list. And that's something we can talk about if you have questions, additional questions after the session. So today we're going to start with the discussion of a medical versus surgical career, and maybe to start off by letting Dr. Kim sort of talk about that, and then we'll get to our backgrounds after.
My pleasure. Thank you very much, Doctor. Nice to be here with everyone virtually. I'm here in the clinic right now, so part of my scrubs. But I just wanted to talk very briefly about the pathway within medicine itself. So the most common dichotomy that is presented in medicine is this dichotomy between medicine and surgery. And so when you're kind of an M2, maybe looking into figuring out what you want to specialize in, most people will ask you, are you interested in surgery or no surgery? And that's kind of the first path. But a little bit more about the medicine aspect, I think it's important to appreciate just how long the training is within medicine. Oftentimes, if you're interested in cardiology, GI, hematology, oncology, these are all paths that require a foundation of an internal medicine residency. So 3 years of internal medicine, and then multiple years after that as a fellow. For other fields within medicine, such as family medicine, pediatrics, radiology, and psychiatry, those are more dedicated residency programs. And so within these programs, the intern year will also be associated with the residency program. It's not a kind of a separate process. And so that's how we often, it's a basic structure to think about medicine. So if you're interested in cardiology or GI or doing some research in those fields, just recognize that it's a long kind of process of training that oftentimes requires a baseline of an internal medicine residency program.
So Dr. Zielinksi, you're is going to talk to us a bit more about some surgical careers. So we have that up here. Maybe Emily, would you like to go ahead?
Yeah, absolutely. Thank you again to everyone for having us. I'm excited to be here. So on the flip side to what Dr. Kim was saying, obviously we have the surgical realm, and within surgery, there are many, many different subspecialties that you can pursue a career in. And so some of these are listed here on the screen, and this is a fairly exhaustive list, but you can even further subspecialize within each of these specialty areas. So definitely, within general surgery, typically that is a 5-year residency. And then there are additional offshoots of cardiothoracic surgery, trauma surgery, bariatric surgery, endocrine surgery, breast surgery, vascular surgery, and so on, as you can see there on the list. So typically for general surgery, it'll be 5 years plus, like you can see there, about 2 to 3 years on top of that to specialize. And I think it's important to note, that pediatric surgery is, you would go into that from a surgery residency, not from pediatric. So it is a special fellowship within general surgery. And then aside of that, you have all of the other surgical subspecialties, such as otolaryngology or ear, nose, and throat. So those are the surgeons that are going to do take out tonsils and do various ear procedures for hearing and other things. Ophthalmology, which Dr. Kim can talk about a little bit more, doing like cataract surgeries, LASIK, things of that nature. Orthopedic surgery, which is what I do, which is typically bony work. So total knee replacement, total hip replacement, spine surgery, and everything within there. And then plastic surgery being, obviously, most people commonly think about probably cosmetic surgery, but within plastic surgery, you can do many different things, predominantly with soft tissues around the body. So working with trauma patients who have lost a soft tissue or have a soft tissue deficit or defect from trauma that you need to move some skin around and things like that. So different types of procedures for that, and cleft palates and things within plastic surgery. You can go into hand surgery. So there's a lot of different avenues, but in general, all of these surgical residencies you'll see are about 5 years of training at the minimum. And then the fellowships out of a surgical residency are typically a little bit shorter. So within orthopedics, for example, you can do a 1-year fellowship in hand surgery. And so that's kind of similar to the above on medical specialties. Cardiology ultimately takes about 6 years of training. And so surgery is not substantially more, but it is more in terms of the residency training. And then neurosurgery is the most involved with a 7-year residency, but they typically do an infolded fellowship. So it's about 7 years total. And they don't do a separate fellowship most of the time.
Yeah, and so when we were asked this question about the present the discussion today, discussion was medical versus surgical career, but actually I kind of realized that this is kind of maybe a little bit of a false dichotomy, and that there's medical careers, surgical careers, and probably the mixed careers, sort of and this is the evolving thing that's going on. And we can think of mixed careers, sort of the ones that have a bit of what we consider classic medicine, seeing the patient at bedside, and then procedural careers, more surgical. And those might be OBGYN, it's about 4 years. Interventional radiology, which is an offshoot of radiology, and it's becoming its own specialty directly. Emergency medicine, that's shorter, it's 4 years. Anesthesia, it's only about 4 years. But then the other hand, the interventional cardiology, this is where you do cardiology in medicine, and then you go over to procedures that actually in total can take 7 or 8 years of training. Pulmonology and critical care, those are the people who've been handling most of the COVID cases in the ICU. That can take about 5 years, sometimes longer. And gastroenterology, the docs who handle GI bleeds and also the initial diagnosis of colon cancer that can also take a number of years. So we'll be talking more about this as we go through about how actually there's a sort of mixing between the two areas of medicine, from the surgical and the medical side. Before we go on to actually talking about our own personal stories, I just want to give a brief historical background. I love medical history. Maybe it's because I'm a little bit older and I have more time. It's just part of the history now, I feel like sometimes. But I think it's important to keep context here. Physicians and surgeons at one time were considered totally separate fields. We're talking way back, several hundreds of years ago. And actually, if you see those barbershop spirally things, I never knew this until recently, but those colors mean something. So back in the 1600s in Amsterdam, the barbershop pole meant that red was set for bleeding their patients. That was a common practice or treatment. White was for pulling bones or teeth. That was another common thing that a surgeon or a barber surgeon might do. And the last was, if they were, not busy with those first two things, they would give you a shave. So it was kind of like those three things. That was the role of a barber surgeon. In the 1800s, the division was still well established in England, and so much so that physicians got a degree, but surgeons didn't really have any formal training, and surgeons became, by historical precedents, became referred to as Mr. So in the UK, when you have a surgeon who went to medical school, they may still refer to themselves as Mr. It's considered an honorific title that dates back to that time. But as the growth of hospitals grew in the status and their ability to treat patients, there was a change in an elevation of status for barber surgeons to surgeons as physicians. And technology really changed surgery, particularly from where it was a salvage treatment. You just cut limbs off or try to drain abscesses, to something where you could actually treat all sorts of diseases. And that the key things there were development of anesthesia in the 1840s, development of antiseptic surgery in the 1860s, and then the use of imaging technology to make diagnoses and then to do surgery correctly at the right spot. And that was in the turn of the 1900s. So just to have a little bit of perspective about that, we can talk about it later. I guess what we wanted to sort of get to the meat of this discussion is to talk about why each of us chose our specific field of medicine or surgery, and what were the factors that led that. And I think we're going to start off with Dr. Zielinksi. So take it away.
Awesome. So just briefly, I started medical school in 2015, which is kind of crazy to think about now. I'm turning 30 this week, so that's pretty wild. 7 years ago, I went straight through undergrad into medical school, and I had really limited exposure at the beginning of medical school. I had done a little bit of shadowing in internal medicine, dermatology, and general surgery via some family friends. But I didn't have any family or personal connections to medicine. So I was a little bit on the outside as far as making other or generating other opportunities for myself. After my first year of medical school, thank you, Jamal. After my first year of medical school, I participated in a summer research program, and most medical schools will offer this to their students as a way to get involved with research. And so my research in particular, the lab I was paired with happened to be focused on bone metabolism and looking at how we can fortify bones by developing different drugs to increase bone growth, essentially. And so I did have a little bit of shadowing with orthopedic surgery from there. And then ultimately, during my third year, I most enjoyed my rotations on anesthesia with the anesthesiologists, emergency medicine, plastic surgery, and orthopedic surgery. So I think for me personally, I did come into medical school interested in doing something fairly hands-on. And so that was really my initial draw to orthopedic surgery. And then I think as I gained more exposure to different subspecialties within surgery itself, I really decided that I liked that I could fix things in orthopedics. So instead of prescribing medications and trying to manage a chronic issue, I liked the instant gratification that came with fixing a fracture, putting a plate and screws on, seeing things line up. Obviously, those bones don't heal immediately, but in general, there's some gratification from seeing that you've kind of impacted somebody's life in that way, or given them a total knee replacement so that they can go on and play with their grandkids. I also liked the balance. I think it's nice having some clinic time to see your patients and see how they do. I personally think orthopedics is the best because I get to see all of my patients in general do super well. And so it's fun to be able to see people back, and it's very rewarding to see the impact you can have on people's lives. And that comes from seeing your patients in clinic and talking to them. And then also obviously being able to do the hands-on aspect and operative time. I do like that it's elective surgery by and large. So within orthopedics, there's many different subspecialties, including trauma surgery, joint replacement, spine surgery, hand surgery, sports surgery for meniscus tears and things like that. And most of the time that's elective surgery, with the caveat that orthopedic trauma is sometimes requires some urgent overnight operating. But in general, most of the cases can be done, during normal business hours of the operating room, 7:30 to 5, so to speak. And nothing is super pressing most of the time. There's very few true orthopedic emergencies. So from a lifestyle standpoint, that was important to me. Like I said, most of the patients do really well. We're lucky to have pretty good outcomes in orthopedics. I also was drawn to orthopedics because I heard about several different service opportunities, which this is probably true in other subspecialties of surgery as well, but to go abroad and do different things. So we have a program at IU with Kenya, with a institution in Kenya, where you can go abroad and teach different orthopedic surgeons there, new techniques from that we're using here in the US, and kind of do surgeries there, which I would find to be very meaningful. And then additionally, I think the biggest thing that comes out of medical school is just your mentors. I think Dr. Kim will talk about this as well. But just your mentors that kind of impact you along the way. I was lucky enough to run into some people who really helped to lift me up and support me. And as a female in a relatively male dominated specialty, it was important to me to have good mentors that kind of showed me that I could do this career and make it in this career. And so I was lucky enough to have people that that kind of supported me throughout the path. And then lastly, I think a lot of it comes down, you hear this in medical school all of the time, but did you get along with people in that specialty? There tend to be definitely some, we'll talk about some stereotypes of medicine versus, or non-surgical versus surgical specialties, but there's definitely stereotypes and different personalities in different specialties. And I felt like in orthopedics, we have a lot of fun. There's sometimes some stressful situations in the OR, but in general, it's a good time. Everybody's having a good time and enjoys their work. And so that was really motivating to me to pursue a career in orthopedics as well.
Man, there is so much love for orthopedics here. You're getting applause all over the place. Ophthalmology is a little bit more of a niche field in orthopedics. And when I'm looking at my slide, I do realize that there's a lot about ophthalmology and why I chose it personally. And if I had to change something right now, it would be to reflect a little bit more just how much change I experienced in terms of what I thought I was going to do. As Avinash mentioned before, I played violin and I had no plans of even becoming a doctor or being in medicine before. I distinctly remember in 5th grade learning about like the light waves and physics. And I thought, I'm not going to be an optometrist. I'm not going to be an ophthalmologist. This has zero impact on what I'm learning. This is low yield for me. But it turns out it's really tough to tell what is low yield for you as you're going through the training. And so I hope my story kind of illustrates that. I think when Dr. Marcel, Dr. Emily, and me are reflecting back, it's really easy to kind of stitch together the dots and kind of draw a constellation among the stars that we see. But really, it is kind of a messy process. It's a very organic process. And it's an ongoing conversation. I'm having this conversation in a different form right now when I'm thinking about fellowships, when I'm thinking about other decisions that I'm making right now. So it's going to be a continuous process. And so I think that comment that Dr. Zielinksi made about finding mentors, finding people that you can talk to that act as a sounding board to you as you're being proactive and kind of discovering this pathway for yourself is going to be super important. I met Dr. Williams, who's an ocular oncologist here, and he just inspired me so much. I always joke around that he is, as a person, is like probably a big reason why I went into ophthalmology. I don't know if that's like a healthy thing to follow a single person to do, but you just got to find those people that inspire you. Just a quick story, I guess. When I was kind of first transitioning from music to medicine, I thought I was going to go into pediatrics. I loved pediatric oncology. I felt like there was a tremendous emotional kind of meaning behind the work of being a pediatric oncologist. Didn't really think about ophthalmology until I actually just got a little bit of an eye injury before before I was actually getting married. So the day of my wedding day, I kind of looked like Quasimodo from The Hunchback of Notre Dame, where he has that one really swollen eye. And like, even though my eye was swollen shut, I guess that kind of opened my eyes to ophthalmology, and I like kind of enjoyed the exam. The exam was like really fascinating, and I think it fit me because you don't really get a lot of exposure into ophthalmology. And so I had to do a lot of the learning myself. And I really enjoyed that process of like learning by myself. And maybe it was very similar to just me being in the practice room as a violinist, just going through, figuring out what works for me and what doesn't work for me. And I'm pretty sure we can say this about all of our different fields. There's so much breadth, even within orthopedics. There's so much breadth, even within just ophthalmology. There's neuro-ophthalmology where most people don't even go into the OR. They just do the exam in terms of measuring the alignment of the eyes and things like that. And although you have the option to have surgery, there's just a lot of breadth. And so it's just a constant decision in terms of figuring out what works best for you. And so that's something I wanted to reiterate to you guys.
Okay, so I guess it's my turn. This is a tough act to follow. We're really Dr. Zielinksi, Dr. Kim with orthopedics and ophthalmology, but I'm going to hopefully convince everybody that radiology is the best. Not always seeming like the best. So background about myself. So I'm clearly the oldest member of the group. My gray hair gives it away, of course. But I started medical school back in 2002, and actually entered the MD PhD program at Columbia College of Physicians and Surgeons. And I was there for quite a long time. It took 7.5 years to finish all the program. And a lot of my initial classmates went on to different fields. So I got a little bit more opportunity to see what people were thinking about. But when I got into medical school, I was really dead set on either neurosurgery or neurology. It was like neuro. My background was always neuro. That's what I started doing my PhD in. And when I got into lab work after my second year of medical school, I started working on spinal injury and ended up doing my PhD in that. I also did my undergrad in that work. And I worked extensively with neurologists and neurosurgeons, particularly the residents who were rotating through the lab for a year or 2 years, even longer. And while I loved what they did, and it was really cool to sort of hear what they were doing and even get exposed to it directly by maybe seeing some cases, I realized from talking to them that there were a lot of sort of quality of life issues that were going to conflict with my goals, my personal goals in life. And I wasn't sure that I wanted to do that. So I thought maybe I started rethinking that. And as I saw my colleagues from medical school progress on and finish medical school ahead of me, I realized that maybe I should consider another option. My rotations that I liked when I got into my clinical year after my PhD were done were internal medicine. I thought that was great. A lot of problem solving that was involved there. Neurology, even more problem solving. You're going to hear a pattern of that. And then I saw radiology and I realized that it's pure problem solving. It's all about solving the problem. And it took away one thing I didn't really like. I never really liked pharmacology all that much. I didn't have to deal with pharmacology when I was in radiology. Just had to learn the diagnoses really well, some of the procedures, and didn't really have to worry too much about the dosing and the this and that and the antibiotics and which was new and the names. It just kind of something drove me crazy there. I also liked surgery. I thought it was super cool, but again, there were some quality of life issues. Now, just for perspective, I started medical school single, and by the time I was done with my PhD, I was married and had one child, and then I had a second child on the way at the end of medical school. And actually, by the time I was in residency, I ended up having, by the end of residency, I had my fourth child. So very busy family life. But independent of the family life issues, I think why radiology? Why did radiology appeal to me? Well, you become a master of diagnosis. That is one of the key things. Think Sherlock Holmes. Actually, the writer of Sherlock Holmes, I think, is Arthur Conan Doyle. He was an MD. But think Sherlock Holmes in terms of like your thought process. You're looking for subtle things that are going to tell you like the next 3 steps down the line, why this is that. And we do that on a regular basis. It becomes almost automatic. We forget it. But when I think about it, I'm like, oh, wow, I'm making 3 or 4 steps of leaps to make a diagnosis based on subtle imaging findings. In general, radiology is about problem solving. You're going to work with other people on the team, other doctors. You're relying on their information provided to you, and then the imaging provided by the radiology technologists to help make that diagnosis. And in many cases, they're relying on you to make that diagnosis because they're busy sort of just managing the patients, and they're not going to have all the time to sort of think through every possibility. Another reason for radiology is I really love medicine. I think it's great. That's why I do this education. this education company. And that's why I got into tutoring myself, was because I love medicine, I loved education. But I didn't really like being in the hospital all day. I found that it was really, really hard for me to want to stay in the hospital. And when I realized that I didn't want to be there all the time, I realized that might not be a good idea. That wouldn't be the best for me if I was taking care of a patient and I really was like dying to go home and it was 6 o'clock and, I still had several hours more cases. So that was a problem. But finally, the last piece here, and this is what we talked about with the mixed thing, is, radiology, what I realized, is becoming very much of a mixed field. You can do procedures, you can see patients. And when I was in the middle of my residency and fellowship, I did hundreds of nerve blocks and other what are called interventional spine procedures. They're minimally invasive procedures, usually take an hour or two, some take a couple of hours or longer, but you can do these procedures along the way. And so you can get very involved. So I knew that if I wanted to get back into it, I could become more clinically involved and could defer that decision-making until I got into residency. So that's why I ultimately chose radiology. It gave me a lot of flexibility. Now, a couple things to point out. Again, I'm done with my training, although you're never done with your training, just to be clear. The learning never finishes. If you're a real professional, you're a real doctor, you never finish your learning. There's no sort of finish line. Don't think that way. You have to think it's a continuum. But for me, now, currently, I live abroad. And I do teleradiology, love it. I work with a very academic group, and we do teleradiology for hospitals all across the US, including major medical centers like Hopkins and Duke and Stanford, and then some smaller places as well. Was able to have time to develop and run an education company. That's great. And also I've been able to travel the world. And this is where I'm going to convince everybody now that radiology is the best. So in 2000, right before the pandemic hit, my wife said, let's move back to the US. Kids need to get more English practice. I said, okay, where are we going to go? We had to pick a time zone that fit my radiology practice. Well, what fit best? Hawaii. We got to Hawaii in January 1st, 2020. Then the pandemic hit and we got locked into paradise for during that period. So I cannot be more grateful for that experience and the flexibility of being able to travel with my work. So it was really, really amazing experience. So locked into paradise. Yeah, we were able to get to the beach because they didn't close the beaches there. And I was able to work in the evening time based on the hours. So it's great. Now I'm back from the US, back abroad. But I still get to do some travel. And now I'm going to start getting involved in AI with radiology. And I can talk more about that if anybody has questions during our Q&A. We have some additional slides to go through just to sort of follow up with this discussion. And then we're going to get to the Q&A. So just going to go to our next slide. And that is sort of talking, I think we've kind of touched on this, but like the difference between medical and surgical specialties sort of is like a feel or a personality. And I think there are stereotypes. And maybe Emily and June, you want to walk through, maybe June, you can walk through the medical stuff and Emily, the surgical. And these are just the stereotypes actually. And then we'll talk about the realities.
Yeah, so these are maybe the stereotypes that I had about medicine when I was coming into it, when I was kind of thinking about things. Maybe we can kind of see these stereotypes in our TV shows about, Scrubs or House MD, how House is, just talking about all these various diagnoses all the time. And, he just is kind of with his team, just thinking all the time. And I guess he does some stuff occasionally, like go into people's houses and things like that. But, for all intents and purposes, they're doing a lot of thinking. That's what I thought that I would be doing a lot as an internal medicine doctor. Thinking, talking. I thought the training would be a lot lighter than that of a surgeon. After all you have to do is think. You don't have to build up the motor skills like a surgeon has to do. I thought the hours would be a lot better. I thought the call responsibilities would be a lot lighter because you don't have a surgical emergency that requires an acute intervention. But I did think that it came with a cost. I thought, maybe your salary would be a little bit lower compared to the surgeons. And this thing about the passive personality also, maybe, I don't think medicine draws passive personalities. I think we all have to have a level of proactivity to like go into the field, but compared to a surgeon who's like always wanting to like go into the OR and like do these interventions, wanting to cut, so to speak. That kind of personality, maybe medicine seems a little bit more passive in comparison.
Awesome. And then, yeah, on the flip side, I know you kind of already alluded to some of this, Dr. Kim, but as far as the surgical specialties and the stereotypes would tell you that the surgeons are spending the vast majority of the time in the OR. They're constantly in the OR and really have very minimal patient interaction because, they're always in the OR and the patients are asleep. So they're not talking to patients. Longer training periods overall. And, because you're building up those surgical skills, like Dr. Kim alluded to, and stereotypes would also tell you it's extremely long hours. You're working, day and night. Obviously there's an 80-hour work week, but I think the stereotypes would also tell you that surgeons work more than that. It's very physically demanding, especially, in orthopedics. Everyone tells you, oh, you've got to be malleting things, hammering things. It requires a lot of like physical strength and grit. Also, stereotypes kind of suggest that you're more directly involved in care, if you will, that you're, fixing things, you're operating, you're changing something about the anatomy to treat the patient as opposed to prescribing medications or something. Stereotypes also kind of comment on, you can see this in Grey's Anatomy and in Scrubs too, more extensive on-call duties. That you're, always there in the hospital responding to the traumas, and you're always like the first person there. So you've got to be awake and basically at the hospital. And then higher salaries generally are kind of advertised for surgical specialties. And it also, if you think about the personalities of people that are portrayed as surgeons, you think about more aggressive, kind of more brutally honest, at times even rude, or kind of conceited, arrogant types of personalities, I would say, are kind of the stereotypes if you think about movies and shows over the years.
And then we actually have the actual realities. And you guys, both Dr. Kim and Dr. Zielinksi covered it really well, but in medical specialties and surgical specialties, there's lots of prep work and lots of procedural work for both. I guess you guys would both agree. There's sort of a lot of preparation that goes into every surgery, and a lot of also there's also a lot of procedural work if you desire it. Sort of depends on your level of engagement. There's a lot of patient counseling. I think Dr. Zielinksi, you were talking about this in our chat beforehand about how you spend a lot of time counseling patients.
Yeah. So I think that on the flip side of the idea that the patient's already asleep, before you can get a patient asleep, you have to talk to them about surgery, and you have to make sure that you're doing the correct surgery for that patient. So there is a lot of patient counseling that goes into it in terms of deciding what, if surgery is the right answer, what type of surgery would be the right answer, what is the appropriate timing of surgery for that patient, and then also counseling a lot on the risks and benefits of surgery, and the expectations of, how much better can the patient realistically get after surgery. And there are a lot of times where, you can't make a definitive promise. And so you're talking to patients and trying to manage expectations that you're going to do the best that you can, but they ultimately may not, more than likely, are not going to be 100% after surgery, but you can make them better, hopefully. So there's a lot of counseling that goes into it, and a lot of talking to patients, and then follow up afterwards. You have to see your patients back and take care of them and any post-operative complications you might have. So there is a lot of talking to patients from that standpoint, for sure.
Yeah, and I'll talk about the next point, and June, I'll be comment on this. So the next one in the list is short, medical specialties, they tend to have a shorter residency, but then they may have longer fellowships. Or surgical specialties, they tend to have longer residencies, but then shorter fellowships. But June, your residency is only how long, and it's surgical specialty? Maybe it sort of breaks
so
that.
Intern year and then 3 years of residency. So it's one of the shorter ones for sure.
Yeah, and so if you're somebody like June and you decide to do ophthalmology, it's only a 4-year residency, total internship and residency period. So it's not that long necessarily to get into a really highly surgical field. One of the things I pay attention to and notice more and more is the idea of part-time or shift work. Radiology is a classic shift work field. We cover a certain number of hours or certain case volume that comes in certain hours, and then we're not responsible after that. So if you're looking for that, that's definitely radiology, but it really is variable. But medical specialties tend to have more part-time or shift work, or what are called hospitalist versions. You have hospitalists internal medicine, hospitalist pediatrics, hospitalists for the ICU. But you can also have that for surgery in certain fields, such as trauma surgery, where they cover only certain hours. The on-call, I don't, my work is essentially on-call. I do ER, a lot of ER radiology, but From what I know, medical specialties on-call can be shorter, but can sometimes be more intense. And on-call for surgery can be longer, but maybe it varies intensity. And maybe you guys can comment on that.
Yeah, definitely. I'm actually, I know maybe I look rested, but I'm actually fresh off of a 24-hour shift. So I haven't really slept much since yesterday morning. So definitely within orthopedics, in general, most of your call is going to be a 24-hour shift, depending on where you're working. And this is true for trauma surgery as well, general surgery, ear, nose, and throat, urology, all of the surgical subspecialties. We typically take a 24-hour call as residents and then even as a staff. But in general, you're only busy if there's patients coming in with your specific specialty type of a complaint. So for example, last night we had several kids come in with fractures. So I was consulted on that, but overall we only had about 5 patients that we were working on. So sometimes you have more, sometimes you have less, but you're not necessarily admitting every patient that comes into the hospital. So it definitely varies. And then from like a down the road standpoint, you can take call as an attending once you're, in your practice, or you can choose not to. I know spine surgeons that have an elective only practice, sports, like orthopedic sports surgeons don't typically take call. And so there's definitely flexibility within that. And you're getting paid to be on call, but you may or may not have work that comes in during that time. So that's definitely true. Some nights I've slept the whole time. So.
Yeah, and I think those call responsibilities are a big reason why they ask you in medical school about that first dichotomy. Are you interested in surgery or not? Because if you are and you are really driven to be a surgeon, I think there are a few things in medicine that might not really be the best fit for you. And it's hard to kind of predict that fit before medical school, before your rotations and before you're exposed to it. Because I know a lot of friends that were interested in surgery that ultimately kind of moved away, and people that never thought that they'd be surgeons step into the OR and just immediately fall in love with it and decide to welcome all those big responsibilities and things like that. I think, when we have call, and it is easier as maybe a little bit lighter than this, as a medicine doctor to have call than a surgical doctor. I don't think many people would argue with that, but does that make it easy for you as a physician to deal with call? I think that's difficult, because I think oftentimes what we do is medical doctors don't compare themselves with the surgical residents. They compare themselves with, people that are not in medicine. And so people that are in medicine have 2-day weekends for the vast majority of time. They have more flexible work hour, more predictable work hours, more flexible vacation times, et cetera. And so it's still pretty difficult. And so it's not by any means emotionally easy. And so I think it's just kind of choosing your poison, so to speak. Maybe
Sure.
Was that too dark? I should have think of a better way to say it. But it's medicine's difficult, and it's important to realize that.
Yeah. Just quickly about radiology and call. When we're on, we're on, and when we're on, it's on. It's like a high fire hydrant of information. I read about 80 to 100 CT cases per shift. It's very fast, especially during the summer. In emergency medicine, when the emergency rooms are packed with people who unfortunately are injuring themselves for reasons of bad behavior, either driving too fast, drinking too much, or doing other illicit substances and causing problems. And so there's a lot of trauma, and then there's a lot of imaging, and we're expected to provide those answers and be right the first time, every time for that. So it can be very, very busy for us, but when we're off, we're off. So that's kind of great. I'll wrap up the last couple points. Salaries is something that's highly variable, could be highly variable overall in medical specialties. Even in surgical specialties, there's quite a bit of variability. That's not sort of the focus of the discussion, but some people really spend a lot of time on it. But tends to be the minimum salaries tend to be a little bit higher overall. And then I think the most important point is that what we're looking for, what all residencies are looking for, and we know this from our residency advising and also medical school admissions advising, and also just generally in the field, we're looking for people who take an evidence-based approach. The idea of aggressive or passive personality, that's not what we're looking for. We're looking for people who are collaborative and are going to look at the evidence and use that to their advantage. We want to think before we do, not just do stuff randomly. So I think that's really, really important. We have just a couple wrap-up slides here. And this is just one I think both Dr. Zielinksi and I were kind of tooling around with. And this is just, I think, and I'm not sure, Dr. Kim, if you had a chance to contribute this, but we were talking about sort of a lifestyle flexibility scale. And this is just our perspective. This is not an absolute scale of relative flexibility of different specialty fields. And by flexibility, what we mean is is a mixture of the amount of schedule flexibility you have, and also the amount of effort that you might need to get started in your career. As in neurosurgery, they may have less schedule flexibility than, say, somebody like myself, radiology. Also, I have more locational flexibility than other people do. But in the other hand, there are certain fields like, say, plastic surgery that might be more flexible in terms of the scheduling, but it takes a number of years in order to get your practice started up. Because if you know a little bit about many of the surgical fields, you actually are like starting your own little small business as you build up your practice and get patients to sort of get referrals to you. So this is just a referral slide for you guys about lifestyle flexibility. And this is by no means an absolute thing, but just sort of to give you a perspective when you're thinking about your future career. I did want to get to our concluding remarks, and I'll let you, Dr. Zielinksi, Dr. Kim, maybe you guys want to just we'll go in order. But I think one of the first thing on this list, I think surgery and medical careers are a journey. And this is, you should think of it as a long journey. Don't think of it as just wait till I get to the end. And when I get to the end, you need to think about the journey longer. It's a long path, and you should enjoy that journey. Maybe Dr. Kim, you want to talk about the second one?
Yeah, and I think the proactivity in terms of like exploring your opportunities is a super important way to kind of figure out things for yourself. There's a question in the kind of Q&A section about how we get the actual exposure to the fields. This is something that some students may expect in medical school, but there's just no way. Medicine is way too broad to be able to give everyone a comprehensive view of each field. Just kind of trust your gut feeling. It's the only thing that you can really go with, and proactively look for those opportunities when they present themselves. If you're maybe a shyer personality, this might, require you to challenge yourself and push yourself to be a little bit more active in the discussions, maybe approach someone who's otherwise intimidating and ask them a question, and then also be enthusiastic about the learning opportunities. As a medical student, as a pre-med student, you're not expected to know a tremendous amount, but what people enjoy and what doctors enjoy is someone who's like enthusiastic about it, and then reminds them about what it was like to really enjoy learning, and makes that process as pleasant as possible.
And Dr. Zielinksi, you want to talk just briefly about the next one?
Yeah, so I think, and for both of them, really, I mean, with mentors, we talked about how important this was. When I was trying to decide, I was really stuck between plastics and orthopedics at one point in time. And I sat down in one of my mentor's offices, and he's actually a general surgeon. And I sat down with him probably 3 or 4 times and just continued to ask him to tell me what I was supposed to do with my life. And he gave me many different ways to look at things, and other contacts to talk to before I was able to finally make a decision. So those people, you really can't get too far, I think, in medicine without having good mentors who can kind of help you figure out how things work, and really build on your experience as you go. So find those people early, and you can always just ask somebody to be a mentor to you, or, ask them to take you to, grab a cup of coffee just to pick their brain. And the more people that you ask about their careers and what they do and why they do what they do, the better idea you'll get about what to expect within different specialties, and kind of different ways of thinking about what a career might look like for you, and what's most important to you as well. So definitely lean on people that you find to kind of make a decision, for sure.
Yeah, and I'll just conclude with the last 2 points. Remember, you are not locked into one specialty. Radiology is known as the specialty that accepts refugees from other specialties. We have many people who are surgeons and other specialties who then left and decided to come to radiology. So you can switch. You don't need to make a decision now, and you can change the path of your career as you go. It's not a locked path. You don't have to fit it. And as I think as Dr. Kim pointed out, give yourself to be open. Give yourself the opportunity to be open to opportunities and to reflect on them throughout. I know we've talked a lot. We've gone about 45 minutes or so, and I know there are tons of great questions out there in the Q&A. So I'm going to move on to the Q&A portion, and you get to hear from us, and we'll answer your questions. And I guess, Avi, you're going to handle the Q&A, moderate the Q&A for us?
Yep, I'll moderate the Q&A for you guys. But first, I hope there's a huge round of applause because, oh my gosh, that was an amazing presentation. Thank you all. Thank you, Dr. Kim, Dr. Zielinksi, and Dr. Brus-Ramer. That was just outstanding. I think you guys made all of your specialties sound like the ideal specialty for me. And I feel like a lot of the other audience members can definitely agree. So yeah, thank you guys so much. And yeah, we can get started with the Q&A. Yeah, just a reminder for all of our attendees, please go to the Q&A section and, ask your question, and also scroll through the list and see if there's any that you also have that you would like to upvote, and I'll ask the ones that are upvoted the most as well. Special shout out to Dr. Kim and Dr. Zielinksi for answering them throughout the presentation, through writing them. That's really nice. But yeah, I guess we'll go ahead and just kind of get started. So let's see. The first question that seems to be the most liked one was from Jamal, and he asked, how is the work-life balance for all of your specialties? I think you guys commented on it a bit and also showed it through the sliding graph, but I'm pretty sure this might be like a more personal, like, how does that interact? How is the job interact for you guys?
I can start. For me, obviously in residency, you don't really have control of your schedule. So right now I definitely, I'm working a lot more than I probably want to be for the rest of my life. But that being said, as a millennial, I do sort of own that title. I'm definitely within the millennial sphere. I think it's work-life balance has become increasingly more important to me throughout the years of my training. And so it's definitely something I'm thinking about. And I think within orthopedics, there is definitely, because like Dr. Kim was mentioning, there are tons of different subspecialties, even within each of the surgical subspecialties. So like I said, hand surgery, sports surgery, knee replacement, et cetera. You have a lot of flexibility to kind of make your career what you want. And so I know plenty of surgeons who have 2 days of clinic per week and 2 operative days per week, and then an administrative day or a fourth, day, a fifth day off, basically. And then some weekend call occasionally. I know Dr. Yang, who I think is giving your presentation next, mentions he takes about 7 days of call per month for neurosurgery. I think that's pretty standard for orthopedics as well. Sometimes a little bit less, sometimes more if you want to take more call. So I think there's definitely flexibility. There's also, I have one of my faculty mentors is very involved in hospital administration. So she really has like 1.5 days of clinic per week and 2 OR days per week. And then the rest of her time is dedicated to resident education and hospital administrative work. So you can definitely pivot into different things within any specialty and kind of explore more the business of medicine if that interests you, and sort of make your career what you want as you go through.
Yeah, I think the question of work-life balance is really interesting, especially because it kind of, you have to weigh it against how passionate you are in medicine. I found it really difficult as a pre-med to say, hey, I'm really passionate about medicine. Please let me into medical school so that I can do what I want to do in life. But then also weigh that with, work-life balance. And so I think that tension between those two values made it difficult for me to answer, at least. And so work-life balance in ophthalmology is generally quite good. The surgeries are quite short. You get to sit down while you're operating. The surgeries are short. But then I also know some great ophthalmologists that have terrible work-life balance, and sometimes and they're just always on, and that's their default, and their families know, and they're and it's mind-blowing to see, and so yes, these fields have these characteristics, but there are always opportunities to make the fields as much as shape the fields to your life. I think with ophthalmology you have more room, more flexibility to like work, kind of shift that balance to more the life side of the work-life balance. But that's how I would kind of describe it. Pretty good, I would say. I think ophthalmology residents and attendings are generally quite happy with their choice.
For me, work-life balance is really was one of the key things I mentioned in my answer. And you can find that, although I have found a way to make it not so balanced because I do too much work, as my wife and my family have mentioned too much. I work too many hours. So sometimes I say, hey, I have this great radiology job with all this flexibility, and yet I probably work a little too much. But I know that I can slow down, and I have a plan to do that. I just spend a lot of time on education as well, which is a big passion of mine.
Thank you, guys. Thank you. I guess kind of going off of that, Rebecca asked, how do each of you recharge after a stressful day at work? And how do you cope with some of the challenges at work as well?
Great question. For me personally, I think I have a dog. He's not technically a therapy dog, but he works pretty well in that capacity for me. But in all seriousness, I think it's really important to prioritize the things that you enjoy doing and not losing those things once you start medical training. Because it's a lot easier to take care of patients if you're dedicating time for yourself as well. And that's something I've realized over the past year and a half in residency in particular. So for me, that's personal fitness, exercise, getting outside, and kind of just hiking or doing whatever. And then additionally, I think it's super important to have a good support system. Sometimes it's hard with family members who maybe don't have exposure to medicine or don't know exactly what you're going through. So I was lucky enough to make several friends throughout residency in other medical specialty or other surgical specialties, actually. So I have a friend who's an OBGYN. My best friend in India is a urologist. My other best friend is a general surgeon. And so it's really nice to have those types of people that you can kind of commiserate with and just sort of share your stories and know that they know what you're going through and they can relate. And I think that's really important so that you can feel heard and understood, and like you're not going through these tough times in isolation.
Yeah, I think recharging is super important. I make sure I try to get some sleep and exercise and get food that I enjoy and schedule time with friends as well. I think an important thing about, finding work-life balance is also trying to create a mental framework so that the emotional drains of your work is as minimal as possible. If you see every kind of patient call or every consult as just another thing that you have to do, and why are people bothering you, et cetera, I think it becomes really tough because each consult is just a drain for you. But if you see those opportunities as a way to kind of give back, kind of contribute to the team and recognize that those doctors are also likely helping you, I'm on the ophthalmology side here at UC, we don't have our own admitting team. And so the internal medicine team does our admissions for us, right? And so whenever I get a consult, it's always in the context of me giving back to the things that they're already doing for me as an ophthalmologist. And so I think the framework in terms of what the work means to you will help minimize the drain that your work has, and maybe kind of makes work a little bit more of a fun and pleasant place to be.
How do I recharge? Well, I love going to the beach. I live in a city that's on the beach, and so I go there as much as possible, even if it's just to look at the sunset while I'm doing a phone call for work or related to my education work. But just if I'm in the beach or touch the water, that's enough for me to sort of recharge me. And try to get into surfing. I'm a terrible surfer, but at least I feel it's a success if I've made it to the water with the board. If I have never stand up, that's standing up is gravy. So that's my recharge.
Thank you, guys. I love all the recharge reasons. Let's see. How about for Dr. Zielinksi? This question was, as a female surgeon, when do you think is the best time to start a family? And during that time, how much availability do you have to raise a child?
Yeah, this is a tough question. I'm not sure that there's a great answer. So I've asked many of my mentors. I do not have any children. My husband and I have talked about it, but he actually just started orthopedic residency as well. So we're both pretty busy. But I think everybody will tell you there is no right time or no perfect time. The best time to start a family and have kids is when you are ready to do that. And that really comes down to a personal decision of how good you're going to be at juggling the demands of motherhood and work. I have a colleague who I revere because she's just she's an amazing person. She's a year behind me in residency, and she had a baby at the beginning of second year of our residency, which is kind of when we start taking the bulk of our call. So that was super impressive to me. Thankfully, residency programs now, I think it can be variable depending on the specialty that you're applying to, but within surgery, orthopedics has recently, the ABOS, which is kind of our overseeing orthopedic organization for resident training, has recently changed their policies on maternal leave and pregnancy for residents. So you are able to take up to 6 weeks off without that penalizing you and requiring you to make up any training time. Historically, that wasn't the case. I realize that 6 weeks pales in comparison to, working in business related jobs like at Salesforce. I think they give you up to like 6 months off or something crazy. So 6 weeks is very small, but you have to remember you are in training. So you only have 5 years to learn everything, or 4 years or 7 years. And that may seem like a super long time, but I will tell you from personal experience, I'm starting my 4th year, and I'm kind of a little bit nervous. I only have 2 years left to learn everything that I'm supposed to know to be able to operate on people. And it's not that long of a time period after all. So I think ultimately you just have to decide, when you're going to have support, who's going to be able to help you, and how much do you want to start a family so that you are able to dedicate yourself to that. And for me, it's not right now, but it's definitely possible. You can do it during fellowship. You can do it during your career. Once you get out, you can do it during residency. You can do it during med school. It's really up to you.
Awesome. Thank you so much, Dr. Zielinksi. And with that, I think that's all the time that we have for this session. Thank you all so much for coming, all of the attendees as well as our speakers today. And it looks like they'll also be staying back to answer some of the questions by typing them. So if you asked any of those questions or you're interested in seeing the answers, then you could stay back for a little bit. But I heavily encourage you. I mean, if you're interested in this whole surgical versus non-surgical specialty perspective here, the next session is a perspective in neurosurgery from Dr. Yang. So if you'd like more information, I definitely would recommend checking out the next session as well. And then also, obviously, the speakers have put in their contact information, the info at Elite Medical Prep. So if you have any additional questions, please reach out to them. I'm sure they would be more than willing to answer more of your questions here. But again, thank you all so much. Thank you to all the attendees, and thank you to all the speakers. And look forward to seeing you guys at the rest of the conference.
Great. Thank you so much for having us.
No worries, no problem.
Take care, guys.
Take care.